And I think it goes back to the county eligibility part of my comments as well, is that that is where these families are going to be entering into the program for the first time if they're not already known to us. And so I think that's also a separate effort that we're working really closely with the counties, because they will be answering questions and helping people fill out the application and understand what it means to them and their family status and things like that.
Mr. Cannella just pulled his hook out, so I'm going to stop. I'm just teasing you. You know, there are issues around coordinated care initiative, health disparities, any number of issues that, you know, kind of fall in your lane that I hope that we will continue to have the opportunity to engage in, you know, policy discussion as a member of Health Committee, and when it's as appropriate during our budget sub-3 conversations. I am clear, I remain clear that the efficient, visionary, clear leadership of this department must be all of our collective priority in order to make sure that all of the residents of the state of California who are touched by your department have as seamless as possible experience in accessing something as critical as healthcare services. When I just fully appreciate the scope of your role as a director, not only in terms of what's in your lane, but then your interaction on Medi-Cal managed care with the Department of Managed Care and Department of Public Health, all of those areas, even though the department has, you know, been divided up over the years, which was important to do because it's big. I'm clear how critical your role is in terms of operationalizing the vision of the legislature. We can set policy and have an idea about how we want to expand services, but it can fall woefully short if it hits the department, it doesn't go any further. So I tip my hat to you in terms of what you've been able to accomplish this year, and know that I will continue to be an advocate and a irritant in really pushing the department to do what we feel it must do for the health of all of California. And so I thank you for your commitment. I applaud you for your effort around capacity building in the department, because that's an area I think government falls short, that we don't talk about building bench strength and succession planning. That's really critical. So I thank you for that.
Thank you.
Thank you, sir.
Thank you very much, Ms. Mitchell. Mr. Cannella.
Thank you, Mr. Pro Tem. Ms. Kent, you and I had a lengthy visit on various topics, and really the areas that I mostly focused on happened to deal with Denti-Cal. As we talked about, it's a program that I think is important, but it's underutilized. It's, you know, the dentists are frustrated. They've got mountains of paperwork, as we discussed. Reimbursement rates are low, and I was encouraged that you've made it a priority to try to fix that, because again, it provides a very valuable service for a lot of poor people in California. So I appreciate that. One thing on the MCO tax, you listed the apocalyptic scenario, in your opinion, if the MCO tax isn't passed, but if the money is backfilled with unanticipated revenue, that scenario won't happen, right? I mean, if we have additional money flowing into the coffers and we just backfill it, then we'll continue going as we have in the past, right?
Right.
Okay.
Yeah. I think what the governor said, and I have now been, again, with the department for 3 times, when the general fund is short, that's where the pain comes. And I think what we're trying to do is put stability on certain financing mechanisms that are there when general fund goes away due to economic cycling and things like that. But yes.
I understand, and when we talked, you were working up a creative solution. I still haven't seen that. I'm sure that we'll be seeing it shortly, and I look forward to seeing that. So I don't want to talk about Denti-Cal again, all the different things we talked about, because we spent such a time, and I was comfortable with your position. But I do have a follow-up question just on the managed care. So when did the Denti-Cal managed care pilot program begin, approximately?
That's a good question. It was probably in the mid-90s is when we put in managed care and other parts.
Okay. The pilot program starts.
For Sacramento
Okay.
is a mandatory county and LA is a voluntary county. And
Okay.
there's only 2 counties.
And how were the providers chosen to be part of that pilot program?
So we would have done, back then, we would have done a procurement. And so dental plans would have bid to be part of the plan network. And so then we would have done regular, contracting duties with them.
So we went
And
out for a
then-
proposal or something, interviewed firms, and then picked the ones probably
Correct.
that were that they
Correct.
thought they were the best suited to do it. In your opinion, how are they working?
I think there have been challenges. I know that a couple of years ago, and this was not at a time when I was actually working at the department, so I got to watch this from outside, but there were some articles and some press about, I think it was specifically focused in Sacramento County, where the plans were not doing what they needed to do. And so patients had coverage theoretically and no dental access at all. And so we put new contracts in place with these plans. We held them to certain quality standards. We did a lot of work to I think we got rid of one plan altogether. And I think one plan may have assumed the lives of the others. So there was some moving around and I think some clear expectations, and we certainly needed to do a better job of overseeing those contracts. And so we have been doing that. I think dental managed care is a little bit of a challenge because it's not like managed care in other ways, in that you want utilization. So you want people to be seeking and using preventive services on a regular basis. And under a capitated arrangement, that's a little bit different. And dental providers are usually paid under a fee-for-service basis. And so that has not, I think, generated the success rates that we want. So we've been in communications with the plans about saying, we want you to do better. These are our expectations. This is what we want to see in terms of access for patients and utilization in patient populations. And so I think they are endeavoring to meet that. And if they're not successful, then we're going to have a different conversation.
Okay, I just think of a pilot program as something that's short-term, and then decisions are made either to expand
Yeah.
it or remove it. Why do we continue to move forward with these pilot programs if they're not working like they should?
I think you have a good point. The rest of our Medi-Cal managed care markets are theoretically pilots as well, and they started back in the mid-90s. So in some cases, it's probably just a historical leftover title. I think if we were to do something different in a managed care setting the way you're talking, we would actually have to create a fee-for-service network in Sacramento, for example, because there isn't one. So sometimes when you end a pilot, it requires a clear decision, and then you'd have to have several years out in order to make the administrative changes to make that effectuate the right way. And so we could certainly do that. I don't think that we feel that the dental managed care plans are, they are trying to perform, and I think we're giving them every effort to do that. And if they can, then that's great. And if not, then we do probably have to call the question.
Yeah. Have you thought about opening it up for other proposals? I mean, maybe competition would get the whole thing working. I don't even know who the providers are, and I don't really
Yeah.
care. But if you're sticking with the same group for the most part and you're frustrated, it seems like if you opened it up and had other proposals, maybe that would be one solution.
Yeah, on dental, there's, I think, 4 providers in Sacramento and 3 in Los Angeles, or I could be off on those. We could, and we could remove individuals and put new ones in. I think that there's probably not that many dental providers in terms of dental managed care entities, but that's certainly something that we could take a look at. I haven't heard that request before, so that's why I was kind of thinking through whether or not that would be a good thing or not. Sometimes in too much competition based on the way the geography is set up, is it Sacramento, do you have enough population for it to be enough of a critical mass for any one plan? So if you add more without taking away, that sometimes will defeat the purpose for what you're trying to achieve.
Well, those are all my questions, and like I said, it was a very interesting discussion. I think that you've got a lot of work to do at the department. I think it's a lot of hardworking individuals, but they provide very important services, and I was very impressed. Every question I asked you, you had an answer. I may not have agreed with the answer, but you had an answer, and it was a very forceful answer. So I appreciate your work and look forward to working with you in the years
Great.
to come.
Thank you very much.
Thank you very much, Mr. Cannella. Madam Vice Chair.
Thank you, Mr. Pro Tem. It's good to have you here, Jennifer, and We had a conversation, I think a long conversation as well, asking some questions. I do know with the MCO, we talked a little bit about kind of a tax exchange that you're working out with the providers, basically, so they're unharmed and don't pass those along to other insured. But what if the federal government doesn't allow that to happen? What is your plan from there?
So, good question. The statute, the draft language that we have, that we're sharing with both staff and the plans, is everything is predicated on federal approval.
Right.
So if the feds do not approve the MCO tax, then we don't collect it, and then we have a different discussion in terms of what do we do after that.
Ms. Kent, perhaps diplomatically and gently, I'd make reference to the MCO tax reform as opposed to the MCO tax process.
I will take that. I will
Right.
take that suggestion.
The wording's always important.
Exactly. I think that and I am not the brainchild of this tax. I hate to call it this tax reform. If it was up to me, I would still be sitting in front of a blank computer screen with an Excel sheet saying, how do I even start? So Mary Cantwell, who is here, is the one who has done this model and all of this calculations in a way that, and she is the Medicaid director, and so she would be the one that would be going back to the federal government and saying, this is the model that we have built in California, here's how it meets all of the federal tests. We are sure that they meet the tests, and so we have run all the statistical tests, we have looked at all the language, and so we are confident that it meets the tests. It's, we have had the hospital provider fee that has been done. We've had the nursing home fee that has been done. These things sometimes look a little different the way we are in California. And so CMS doesn't have a reason to reject this tax for meeting the test. So we are pushing the envelope a little bit, but we're feeling positive about it. And if it doesn't pass, then it's a whole different conversation.
Right, right. And that's the question, if it doesn't pass. Are there other ways that we can fund the necessary needs, basically through the budget? Not currently what the budget is proposed, but other budget means that we can work out between now and June.
Yeah, thank
So
you.
that's important to me. The other one, we talked a little bit about the California Children's Services Program and the whole child model that will ensure access to CCS providers, maybe who aren't willing to accept the current Medi-Cal level reimbursement. Tell me a little bit more about that.
Sure. So CCS is, as I said, one of the oldest programs in the state health world, at least, started in 1927. So it is not with any kind of disrespect that we are talking about trying to change it, but I think it's also in recognition of there are children that are receiving CCS services today that get CCS services in a fee-for-service environment. They may be enrolled in the Medi-Cal Managed Care Plan for their non-CCS condition. They may be in a regional center for a regional center need. If they have specialty mental health, they will be in the county mental health program. And so, as I said, that is really bifurcated, and for a child with a complex or serious health condition, not an ideal situation. So what we have proposed is to enroll these children into the county organized health system. So there's 4 that we would say these children will be the plan's responsibility for all services. They would be responsible for contracting with CCS providers. And so we panel CCS providers at the state. We have quality measures and requirements. We would not change any of the CCS quality standards, and the plans would have to contract with those providers. If plans refuse to contract, in terms of if CCS providers refuse to contract with the plans, we have continuity of care requirements that would be in effect. So a child being enrolled in a plan, if they had an established relationship with a CCS provider, that plan would have to either pay them the CCS rate, which is an enhanced rate above what Medi-Cal rates are, or the plan's contracted rate, whichever's higher. And that would be the default if the provider for no other reason would contract with the plan. So we have tried really hard to be thoughtful both about the transition as well as about the market forces that are in play when you're talking about providers and health plans contracting with each other.
Right, and we talked a little bit about how many thousands of children are
So there's about 200,000 kids in CCS today, and we're talking about moving about 18% of them, so it's 17, 18,000 kids.
I mean, it seems like a good model that, you know, they get care from everywhere but only have one provider. It seems like a good idea for
Well, and I think,
parents.
and it's important, I think what's important to assure both ourselves and policymakers as well as the families, back to the measures and accountability and transparency, is what are we doing to make sure the plans are ready to receive this population? Have we done all of our network certification and looked at all of our things that we need to? And then what are we doing to measure the plans after that population's enrolled so that there's transparency on the outcomes on the back end, which I think is
Well, right now, you can't see
responsible.
the outcomes.
No, I mean, I can tell you what kind of services we paid for, and I can tell you how much money we spent, but in a fee-for-service environment, there's no real quality
Right.
measure, right?
Right, good. Yes, and I appreciate, you know, when we talked about the dental, being able to add that, and Delta Dental, I mean, my dentist takes Delta Dental, and it seems like everybody else takes Delta Dental, so it seems like a good provider, at least for my counties in LA and San Bernardino County, so I'm glad that's happening,
Yeah.
so thanks so much. And thanks for spending a half hour, 45 minutes with me the other day.
Not a problem.
Thanks.
Thank you very much.
Thank you very much, Madam Vice Chair. Ms. Connie Leba.
Thank you, Mr. Pro Tem. Good afternoon, Ms. Kent. Thoroughly enjoyed meeting with you. Your breadth of knowledge is very impressive. I also like your direct and decisive nature. I think that makes you a great fit for this job, and any job, really. My colleagues have done an excellent job of really probing into all of the questions I had, and I've checked them off my list. So what I am going to ask is, at the end of your tenure, what do you hope to accomplish, and what do you hope that the department will look like?
That's a good question. Ideally, I would like to know in my head, I wouldn't say it out loud, but I would like to know in my head who the next 3 directors are, right? I would like to have really engaged, eager, up and coming managers where I'm like, this person, they're going to stay with the department, and 10 years from now, they're going to be running the department. And that person, in 15 years, they're going to be running this department, or they're going to be the Medicaid director. I mean, that I think is the biggest goal that I have really walking out, is a department that is running well, that has good business processes, that has stable IT systems, that has, a functioning and efficient set of encounters that we do as government that people are proud to be a part of or proud to be interacting with. And then obviously having individuals that are willing to stay and continue to serve. That's really important. And that's basically all I ask.
Thank you very much, Ms. Leba. We're going to go back to Ms. Mitchell.
I just have one final question. I remembered an experience serving as a member in the Assembly Health Committee. It was a very tense hearing where we were talking about accountability and transparency and developing metrics, and the legislature was asking your predecessor questions around guaranteeing access to care, and if plan coverage was going to be equitable across the state. So it was those kinds of conversations. And I had an aha moment and asked your predecessor about accountability, that I have a job performance evaluation, also known as Election Day,
Yeah.
where constituents and the voters and residents of the state of California can let me know in a very clear and direct way whether they think I'm doing the best job possible. And when we were considering, coordinated care initiative and lots of new policies, we were still talking about how we were going to operationalize the Affordable Care Act. So with a lot of moving parts. And it just hit me. I have a performance evaluation. How do we then hold this person accountable for the success of all of these policy changes, dealing with very fragile populations? So I would ask you, how are you held accountable by the public? How do we hold you accountable in really making sure that no harm is done?
Great question. So we have those metrics, and we have that accountability. In one of my previous jobs that I held before, I was a consultant for a private Medicaid consulting firm, and so I worked with a lot of plans in a lot of states, and it was interesting to see how other states operated their Medicaid lines of business. But what we have, and I didn't see it anywhere else, were the dashboards that we do. So we issue quarterly dashboards and we publicly post them, and we have certain measures that we have all the plans reporting encounter data and other kinds of pieces of data to us, and then we publicly post it. So on any given quarter, you can say, how did these plans do on 30-day readmissions for individuals who have left the hospital? And so we will, on a plan-by-plan basis, show how they met that metric. We look at their financial health. We post that publicly. We have certain other appeals and grievances are also posted. So, and then you can see as they stack up against each other where your high performers are and where your low performers are. We have a mirror dashboard for CCI. We will have one for CCS. That, I think, is something that both I'm proud of, but I also think is something that is not being done in any other state yet that I know of. So from an accountability standpoint, if you ask us, on the broadest, highest level, are you confident that people are being served and that the plans are hitting certain, standardized quality measures, and are you looking at that on a regular basis? The answer is yes. And we continue to improve the data that we're getting from them. So we have a lot of quality data encounter proposals, and we're working with DMHC on provider directories and other things. Those all go into some of both our report outs and stakeholder meetings, but a lot of it we're trying to put on a dashboard that you can see most readily. And I'm happy to give you copies of ones that go back for a year or two, just so you can kind of see how things have either changed or progressed.
And to get back to Mr. Cannell's point about why a pilot didn't work, why did we stop? So that's the measurement. And what are you then empowered to do, and what do you do when the dashboard is showing red versus green?
Well, so
Because that's, from my perspective, is the accountability of you as a director of the department.
So when it comes to administrative authority over the plans, I think we have a lot. And I, as director, we as a department, we have contracts in place with each and every plan that have a variety of things that can happen. If plans aren't performing, we can freeze enrollments. We can, the worst is obviously from a plan perspective is terminating the contract. We have financial penalties that we can levy against them. We have corrective action plans that we have plans under. If they don't come out from underneath that corrective action plan, we can penalize them. No one has done that yet. One was close and they have corrected. And so we publicly post our audits. We publicly post our corrective action plans with the plans. And so there has been a renewed effort and interest in accountability. And I think we owe it to folks, but also if there is a plan that is not performing, we have a variety of tools in the administrative toolbox to either correct the behavior or change the contractor.
Thank you very much.
Thank you, Ms. Mitchell. Ms. Kent, let's go back to the MCO tax. I'm not going to reform, I should say.
I wasn't going to remind you.
We won't get into the micro issues, but I know there's been a lot of hard work on part of the administration, and kudos to the administration and for their hard work on dealing with this issue, because we know that if we don't strike some sort of deal, that we'll have $1 billion hole in our general fund budget. And obviously the alternative is not very good, because we'll be in a position of making some very difficult cuts, which will impact the most vulnerable we have in the state of California, coming off the worst economic recession since 1929, where they've already suffered a tremendous amount of cuts that we have yet to, as a legislative body, as well to the executive branch, yet to fully backfill. So with the current negotiations with the MCO tax reform, is this a measure, in your opinion, that is bipartisan and should expect a bipartisan support?
I think we have, offered a deal that should receive bipartisan support. I think we tried really hard to mitigate the concerns expressed by the business community and by others about whether or not it would have impacts on the non-Medi-Cal lines of business and the impacts on small businesses and small employers. And so what we have done is a really aggressive proposal that I think meets those concerns. So I would hope that we are trending in the right direction, and I've been heartened by some of the conversations that we've had so far. No one has said no. And people have been willing and able and eager to listen in terms of understanding the proposal and asking questions. And so, and that goes to people on both sides of the aisle. And so I think that I feel that we are in a positive place.
Could you give us a synthesis, perhaps a synopsis of some of the commentaries from the business community?
I think that when we have talked to some of the members of the business community, they've looked at the overall big numbers of the tax. So when you look at the tax reform in its entirety, you're raising money, you are paying back the plans, the Medi-Cal plans for their funds, and you're doing these tax reform changes that have net impacts to the health plan industry. And at the end of the day, on our model, it's showing a $90 million benefit. So that, I think, has been helpful to the business industry in terms of seeing that and saying, okay, this doesn't look like a tax increase, has been, I think, the general response. But again, you know, there's a lot of detail and each plan is impacted differently. And so it's really hard to speak in broad generalities because each plan is structured and handles their business and taxation in a different way. But broadly speaking, we have constructed something that I am hopeful that we can reach bipartisan support.
And that we're in a good place, in a better place than we were a few months ago.
It has come a long way.
To deal with the big issue. Obviously, you have a very tough job. You have not a lot of takers for this specific position.
I don't think so.
Okay. If my understanding is correct, obviously you're here. I don't think you're here for a glutton for punishment, but you want this position too.
I wanted this position, yes.
Yeah, you want
I still want this position, yes. I wanted it. I still want it, yes.
So obviously some of the skeptics that you have say that you're really data-driven, perhaps data on steroids with regards to metrics and valuations. The sort of issue with regards to fiscal constraints and obviously the humanistic issue here. I will say this. You're a very, very competent administrator, and it speaks volumes that you really want this position also too. In a bipartisan fashion, given that you work with then Governor Arnold Schwarzenegger in a Republican administration, you do get kudos from folks on both sides of the aisle, especially those who deal with the complexities of healthcare policy. So there is really positive affirmations of your abilities in the current position that you're in. So I'd like to move forward this nomination. I know before we do that, we're going to have folks who are going to speak to your nomination. We're going to go to those who are in support of Ms. Kent. What I'm going to ask is this, because we're running on a really tight leash right now. This went a little longer than expected. Those who are in support, quickly identify who you are, and I'm going to ask you to guarantee Ms. Kent's confirmation, at least before the Rules Committee, that you be extremely, bless you, short in your comments, because I want to go through this very quickly.
President, members, I'm Gary Passmore with the Congress of California Seniors. I've sent you all a letter. We're really proud and enthusiastic in our support for Jennifer Kent. This is a killer job. It's a tough job. And I just want to take 10 seconds to say not only does she bring the technical competence that you've heard today, she understands the politics of this job with a small p. I've never known a time when I had an issue or a question that she wasn't available to help. She has reached out to stakeholders and advocates like me for seniors to get our input both officially and unofficially, and she manages those kinds of politics brilliantly, and we are really strong supporters.
Thank you, Mr. Pastor. We're going to have to go a little quicker than that. Let's go.
Mr. Chairman and members, Scott Witch on behalf of the State Association of Electrical Workers, the California State Pipe Trades Council, and the Western States Council of Sheet Metal Workers. I represent nearly 100 Taft-Hartley health and welfare trust funds. When Ms. Kent was in the Schwarzenegger administration and had no political necessity whatsoever to be open and concerned with how we operate and our issues, she always was available to us and learned our issues, probably knows how they operate better than anyone, and with that type of track record, we urge your ice.
Thank you much, Mr. Wetch. Next witness in support.
Karen Karp from the California Association of Nurse Anesthetists, representing 2,300 certified registered nurse anesthetists in California that primarily serve the medically underserved and critical access in rural communities. We are extremely appreciative of Ms. Kent's work, and we support her wholeheartedly, and we look forward to working with her.
Thank you very much. Next witness in support.
Beth Capel on behalf of Health Access California. We have worked with Ms. Kent in both administrations and in other capacities, and despite that are here in support.